Next, Mareka. I just have to say before Mareka starts, the fact that Mareka is presenting on CP and I'm not is a huge win. So yay, Mareka. But yeah, I think everyone's heard kind of Mareka's background and her, I don't have to do too much more about Mareka's bio-sketch, but I think the work she's done at Manguzi and just reworking systems, collecting data, that is a huge win. Yeah, thanks, Mareka. We look forward to it.
Okay, so I'm going to do a disclaimer. I'm going to do two disclaimers. Number one, I'm not a CP expert. I do systems. And number two, this was a very last minute presentation put together. It's not pretty. Okay, so Manguzi's CP program was not bad by any means in 2018. New CPs were identified consistently at a very young age through the department's flagship high-risk baby program. The mothers received early counseling from the OT technician and received both individual and group interventions on a monthly basis at their closest clinic by occupational therapists. Groups were also run in conjunction with the only parent facilitator, Sma over there, and were structured around themes which drew in dentists, dietetics, and speech therapists on a routine basis according to the topic that was being discussed. When the children became too heavy to carry to clinic, which is usually, as Gillian said, around between the ages of 6 and 8, they were discharged from the groups and individual rehab sessions and occasionally received seating services, often only if they sought them at hospital level, which was a very costly exercise for the family, or the occasional home visit from the home-based care nurse and community OT, which focused mainly on the provision of nappies and in addressing psychosocial concerns within the family, which is important, but insufficient. Few young children received buggies, with the limited budget being spent on the older children who were still on the waiting list. A few received rudimentary APT box seats, so that's advanced paper technology, but this was not the norm, and only one child had actually received a standing frame. There was a high loss to follow up, and although this was monitored, so we knew that the kids weren't coming to therapy, no response occurred, so it didn't trigger anything to a child who didn't arrive at an appointment for longer than 3 months. So no monitoring, and there was no monitoring of the older cohort at all. There was much that needed addressing, stuff that if you attended my team's presentation yesterday, I have already covered. Urgent attention to governance and team dynamics was needed. Program silos needed to be broken down. Therapists in charge of programs needed to ease up the reins of control, and complete restructuring of how we collated, managed, and used our data was needed. There were ethical decisions that needed to be made about how the wheelchair budget was spent, and creative ways to address budget shortfall was needed. We also needed more parent facilitators because they're amazing, and we needed to formalize our working relationship with them. To make the whole thing more sustainable and comprehensive, we also needed to integrate the CP services into the current primary healthcare systems and structures. The problem is we didn't really know what our baseline was, so it was impossible to really say how well we were or were not performing, and whether any reforms would yield results. The patients on the CP database did not all have GMFCS levels, type of CP, or sometimes even contact details recorded, because different therapists, including ComServes, had placed kids on the database without it going through the one person in control. This made it impossible to guesstimate what our coverage rate was for the population, but it also made it difficult to budget, and it also made it difficult to plan for services properly. The wheelchair database was separate from the CP database. The buggy waitlist was paper-based and not shared with the wheelchair database. It was impossible to see what exactly was being done by the therapist in the session at home because the patient had a patient-held record. At clinic, they had a clinic file. At hospital outpatient, they had an outpatient file. And if they were admitted, they had an inpatient file for that particular admission. Parent facilitator interventions were not recorded at all. What we needed to do was to consolidate all these things into a single electronic patient record and see how we could track performance of key services related to the CP service, namely the individual rehab sessions, parent facilitator sessions, and wheelchair services. We also needed visibility of waitlists for the different types of devices. We needed to pull the service into existing PHC structures and ensure that chronic medication needs were addressed and reviewed, and that access to consumables was more consistent. The same issues plagued the wheelchair services. Although it was decentralized at clinic level, so every 6 months the clinic would get wheelchair repair, reseating, review services, this often excluded advanced seating cases just because of the time that it takes to do the review and do the actual advanced seating case. And because of the fragmented nature of the databases, many kids who received their buggy were never reviewed again for size, fit, or appropriateness of device. We could not possibly meet the need either with the current budget that was given to us. But there was light. In 2019, a lot happened. A decision was taken to spend the entire wheelchair budget on 14 buggies and spares to repair the adult wheelchairs. The Rachel Swart Fund supported individual patient applications for 13 buggies and took on the monthly stipend for SMA over there. Manguzi's MSDI NPO is awarded Discovery's Distinguished Visitor Award, and the objectives included improving the quality of care provided to CP services, integration of parent facilitators into rehab services, and addressing data management. Furthermore, due to the rising litigation, KZN Department of Health supports the rollout of CP training for therapists and requires departments to submit a QIP for their service. Actually, I'm not sure if KZN did, the Department of Health. I think that was Gillian. Anyway, we had to do a QIP, which was good. Although also due to COVID, this only really rolled out in 2021. And although this was delayed, this initiative really assisted us in discussions around involving the wider rehab MDT question approach and held us accountable to the proposed reforms that we had given her. And opportunity always knocks. So firstly, the Department of Health had a curveball, but it had a silver lining, and it supported our initial conviction that we needed to better integrate the service into existing PHC structures. The home-based care nurse was redeployed to clinic, and all home-based care patients, adults and kids, were then added to outreach team leader lists per clinic area. They were also added to the clinic monthly consumables ordering list. But our outreach team leaders didn't have access to transport, although they were outreach team leaders. But we did. So it needs to work for both parties. So a deal was struck that we would pick them up before we went on home visits via the clinic, and then they would accompany us on all our rehab home visits. And suddenly, your patients became our patients. So it was a win-win for everyone. And then lockdown happened, essentially disrupting services entirely. The rehab team became very concerned that those with level 4 and 5 would develop significant secondary complications over and above what many of them already had, should services be disrupted for any longer. We were also hugely concerned about kids and adults known to have poor social support, but also cognizant of the fact that many families' social circumstances may have changed dramatically during lockdown. And we would never know that until the person landed up being admitted in the ward. We also knew that we had a high loss to follow-up rate already, and that most of these were unknown to clinic staff. So the team made a conscious decision to shift all moderate and severe disability services to home level at the end of lockdown 5. This finally gave us the impetus to combine all the separate program and service databases. But for CP, it also meant trawling through additional paper-based records and files. It was a really massive undertaking. Guys, it took me 3 months. But we needed a baseline. For reasons of time and caseload, we engaged in an explicit prioritization and triage exercise with the full team. Priority 1 were those lost to follow-up, those with known poor social circumstances, and those who were considered medically unstable or at risk of deterioration in their health. A multidisciplinary team went out daily, traced clients lost to follow-up, and reassessed clients for baseline needs. A lot of task shifting and upskilling was needed. We also found a lot of broken promises made over the years by therapists around assistive devices and promised home visits that never happened. There was a high level of unmet need, and additional resources were required if rapid changes were to be expected. If we wanted to do this slowly, we could do it slowly, but it needed to be done now. So where did the resources come from? So OSF supports RHC in a rural COVID-19 response. Obviously, Marika jumps on the bandwagon and says, well, we need a disability-specific COVID-19 response for rural. So OSF sponsors the hiring of a disability-specific COVID outreach vehicle for the rehab team, supports the design and development of the electronic health record for rehab, the INSMA is part of. It's built around the individual client record. You've got a landing page with very basic general client demographics that you would collect for everybody. Then for CP, you've got a landing page that includes the GMFCS, MAX, EDAX, and then more questions around socioeconomic status and like grants, which grants the family that each from the same part is getting, what the transport costs are with the buggy or the wheelchair and the caregiver to clinic and then to hospital. There's a separate landing page for wheelchair services because obviously you want extra data around whether the person is intermediate or advanced user, what model, what serial number, what the frequency of care is for follow-up for there. And then you've got multidisciplinary rehab notes are now consolidated under that client-specific record, and activities are then linked to the CP or the wheelchair program or both, so that you can then filter and sort for those things. Frequency of follow-up is required and stated for rehab and then for wheelchair services separately because they may be very different frequency of follow-ups. And then all of that data is then pulled in automatically into program performance data and sorted by clinic area, which that means that my physio, OT, and speech that are linked to that clinic area will then have a list of we'll have feedback on the performance of their services for the CP program, their services for the wheelchair program. They'll have lists of who's supposed to come in for clinic, for follow-up dates, etc. High-risk baby as well, that's another program that's linked. So the competition is to turn the circle blue, as in you've met all the frequency of care cover follow-up appointments that you were supposed to do. If you turn the circle green, it means that all your patients have been lost to follow-up. Yeah. So we were also fortunate enough to expand the parent facilitator service. They started off by tracking and tracing all the lost to follow-ups on our list, and that was a list that was started, I think, in like 2010 or something. So there was a lot of stuff on there that nobody had seen the kids since. And their task was to just reassess baseline needs initially, and then triage kids into the various services that they required, and then get them back onto the rehab program, and then get the DOH therapist to go out. Reorganize the data, train two new parent facilitators. Twice a month, they were having case management discussions with the therapists because there was a lot of upskilling that was required in problem solving. The focus was on home visits now instead of groups at clinic, because it was still a very uncertain time. Then we had new home programs. We decided that we needed to know what the parent facilitators were doing, and the mothers also needed to sign accountability for the fact that the parent facilitator had been there. So we had separate books, because they are not integrated into the Department of Health yet, separate books for parent facilitator visits that the mothers held at home. The parent facilitators were also recently trained further in basic seating and repairs, which gave us further efficiency gains, because often it's just a small thing that's needed, and then Marika has to be pulled out of management, drive all the way to the homestead and just do the small little thing like twist a bolt or something. And then there were monthly reporting to clinic therapists by the parent facilitators on what they had done, whether there were any problems to be flagged with the kids in their clinic area, whether they wanted to go see the kids with the therapist themselves. And they have recently embarked on getting their driver's licenses. So Sma has got her driving license. She also drives my bakkie, so I trust her. She's also driven donors around, which made me very, very proud. And the other two are still, one's got her learners and is trying for her drivers, and the other one has to get basic documentation. So, and there were even more better things that happened. This was in facilitators, and we finally start to look at the standing frame deficit. So 3 out of 24 kids had actually by 2022 received a standing frame ever. Kids had received an APT standing frame. The KZN Department of Health got saved 97,280 Rand. Thank you. And it improved coverage rates from 12 to 79% in 7 months. So that's amazing. Thank you, Sma. The challenge, obviously, is that it is, APT is time consuming. So if you've got block therapy running on a continuous basis, like Tandi managed to get going in Madaleni, you can get the parents actually doing it under supervision. But if the parent facilitators are doing all of the APT, it means that you've got a limited budget to pay their time spent seeing CP kids at home and in groups, as well as them making the APT, because they get paid on a per hourly stipend. So one suffers. So what was amazing was that an additional donor has just come on board and offered to purchase the APT devices made by them, so that they won't bill for hours. They will just sell the device to the donor, and then the hours are then spent actually doing the CP mentoring, which is like really cool. So what was the effect of all of our reforms? So just looking at the socioeconomic data, we took real-time, and I have presented on this last RHC, but for those who weren't there, we took real-time clinical intervention data from our electronic app. So it's according to the frequency of care that we think the kids should be seen at. And we took their reported costs round trip to clinic, round trip to hospital. And we took all of their grant income. We used that as a proxy for consumption data, because we just don't have that kind of stuff. And then we calculated catastrophic health expenditure based on the real-time data of the number of interventions that they had, but then we modeled it. We took the first line, just tells you about the service as it is now, what percentage of our CP households would be pushed into catastrophic health expenditure right now with our home-based care model. Then we took all of those and we said, well, what if it was mainly held at clinic level? And then we took the same data and we said, well, what if we only held services at hospital level? And it's really, really, really shocking. So I think the current CHE for South Africa at 10% is 1.2% of households would be pushed into catastrophic expenditure, 1.2 or 1.9. But if you look at the 10% column, it is an astronomical percentage of our CP households that would be pushed into catastrophic health expenditure. And here we are blithely saying that like clinic-based programs would be fine, sort everyone's problem out. This is why kids drop off the system when they get too heavy to carry, and this is why you never see your buggies ever again. So, then we looked at 2018 data and 2021 data. We looked at it from the same months. So we took April to September because that kind of like included public holidays and excluded the time when, you know, ComServe turnover, which is chaotic period, and then Christmas when everyone goes on leave. So we took those 6 months. And we just looked at a number of indicators. And as you can see, I think that the way that we reformed our services and the things that we did dramatically changed. Significantly. So coverage rate from the 0 to 5 population went from 58% to 78%. And the 6 to 12s went from 43 to 93%. So we picked that age group up. In the 13 to 17-year-olds, it went from 21 to 87%. Average number of rehab sessions received by clients in the last 6 months went from 1.3 in the 5-year-old group to 6. So at least they got a session every month, which was good. That was during 2021 is COVID as well. So this really isn't bad. 6 to 12 went from 0.7 to 4, and then 0.3 to 3.7. And then, yeah, home visits. You can see that the OPD sessions reduced in certain age groups, but that's because we'd shifted everything to home level. So yeah, I think that from a dosage point of view, I think we did really well with our model. Then we looked at the wheelchair and seating services, and again, like, was particularly good. And that was because of so many, a multi-pronged approach to getting like more devices into the system and reviewing more devices in the client's homes. So coverage rates, like number of kids actually receiving an appropriate device, went from 32 to 83% in the 5-year-old group, 73 to 95 in the 12-year-old group, and 18 to 100% in the 17-year-old group. In 2022, I've just crunched the data, and we are 100% of all of our known cases that require wheelchairs in the 6 to 12 and 13 to 17 and 18 plus group have now got their wheelchairs. So seating review rate, a client received at least one follow-up in the review in the last year. In the 0 to 5s, we never saw those because they never brought the buggy to clinic because it's too expensive, and those kids never got the home visit because they were being seen at clinic. So we went from 0 to 80%, and then 17 to 84 and 50 to 88. And then we looked at it as to whether they even got 2. So 1 every 6 months. And that also improved dramatically. The average age at which the client got their first wheelchair went from 4.4 years, which is still not bad, to 2.1 years. So again, like massive change. But a word of caution. Okay, so coverage calculations depend on a denominator. And denominators depend on how your cohort is defined. The more information, if you've got a massive cohort, and like 60% of this cohort, you have it as lost to follow up, but you don't know if they've died, you don't know if they've moved, you don't know if they're actually not a CP in the first place, but somebody put them on because they just wanted them followed up. Like, so the more you start tracking and tracing, the more information you get back, the more your cohort changes in your denominator. So the stats that I've just represented, they're not the absolute truth, okay? But I use the same denominator to assess the 2018 and the 2021. So it is a real-time reflection of the improvements that are made between those 2 years, but it is not the absolute truth of what is truly out there because I'm still trying to find some of those CPs on the list. But I think it's a start. And number 2, I think that this is the kind of data that we need to really start discussing. Can it be sustained despite major transport disruptions? And despite health utilization rates for rehab really picking right back up to normal, besides our clinics, which is 75%, home visits being pushed up to 300% of pre-COVID levels, and COVID response staff being withdrawn from peer support or parent facilitator NPO, the data suggests, yes, we're doing fine. So key messages, same as Gillian, decentralize, data management is key, integrate into systems, ethics, budgets, connection, and creativity. Have a hard look at your efficiency, your undergrad training, and your team dynamics, and invest, where is that guy? Invest in parent facilitators. They are like gold. They will really, really change your program around. Thank you.
Okay, thanks, Marika. I think the key from there is data is important. And parents are facilitators, and I'm always going to say it, but I'm always pro online records and online data.